Yeah, I can't break my record of starting at 8:01 and try to get up here soon. So the fire extinguisher has just been checked, so we are safe there. And I want to welcome you again to Grand Rounds, and thank you for spending this hour with us. And we're going to have some great learnings about nephrology today. So my little side note is that we have 20 days till spring, so that's really very exciting. And I will be here next week introducing Grand Rounds, and then after that, that will be the last time you'll have to put up with all my little crazy introductions. So with that, I am very honored to have one of our nephrologists presenting Grand Rounds today. This is Dr. Fahad Aziz, and his Grand Rounds is update on cardiac disease and kidney transplant. When I talk a little bit about him, you'll understand why this is an area of interest to him. So Dr. Aziz did his medical school and received a Bachelor of Medicine and Bachelor of Surgery at King Edward Medical College in Lahore, Pakistan. He then did his internship in Jersey City Medical Center in Jersey City, New Jersey, and he did 3 fellowships, 1 part fellowship and 2 full fellowships. So he did a year of cardiology, and that was at Penn State, and then he went on and did nephrology at University of Missouri, and then came here to UW and did a fellowship in transplant nephrology here at University of Wisconsin. He has been incredibly productive. He joined us on faculty in 2017 as an assistant professor of the CHS track, and he has had 29 refereed articles, and 15 of those have been since he's joined us on faculty in 2017. I love to look through CVs, as you know, and one of the things I learned is he's really involved quite a bit with teaching and does a lot of classroom teaching and CME teaching. And in addition to students and residents, which almost everyone does, he does a lot of work with the fellows and has done work with our physician assistant group, which is fantastic. When I looked at his awards, that really reflected his clinical and educational excellence. He received the Best Resident of the Year in 2011 and 2012. And in 2018, he received a Clinical Excellence Award, which was titled Clinical Excellence Award from the Division of Nephrology in the Department of Medicine. And so with that, Dr. Aziz, please come up and present Grand Rounds. I see a lot of nephrologists in the room. Feel free to come to the front.
Hello, good morning, everyone. Thank you very much, Dr. Trowbridge, to give me opportunity to talk over here. This topic is very important to me, and that tells you why I have 3 different fellowships coming to this route. When I was doing a heart fellowship, I find out many people, we do the stress test just to clear them for a kidney transplant surgery. We clear them, but however, they're bad outcomes. They have any kind of cardiac event after the kidney transplant. During my nephrology fellowships, I have seen high mortality of people who are getting dialysis, and the hope is to get them to a transplant where they will do much better. In the transplant fellowship, I noticed that when we transplant these people, they go through a very aggressive cardiac testing before they get a kidney. And despite that, we improve their overall mortality, overall lifestyle as compared to people who are on dialysis, but we continue to lose them, sometime even early in the course. And this topic is also very important, not only for transplant nephrologists, general nephrologists, and cardiologists, but it's also important for all of us. Because now as the pool of the transplant people are growing, we are dealing with these people, all of us are dealing with these people in some capacity. Being a hospitalist, being a critical care physician, being a primary care physician, we are linked with these people. By saying so, I have no financial disclosure. So learning objectives for today's talk are 3 main objectives. I want to get you guys know what's the prevalence of cardiac disease in kidney transplant recipients. Then we'll go to the risk factors. What are the risk factors associated with kidney disease in this special group of people? In the end, we will talk about what's the risk stratification and how to prevent this disease in these people. To achieve my learning goals, I have divided my presentation into 4 major sections. In the first section, I will talk about what's the prevalence of cardiac disease in all the kidney transplant recipients. Then I will go down to the risk factors, which are transplant-specific risk factors and the traditional risk factor in this special group of people. Then we'll talk about how to screen these people for cardiac disease and how to prevent the cardiac disease in these people. In the end, we will come up with some conclusion, some future directions for my own research. So let's talk from the beginning. What's the prevalence, what's the magnitude of this problem? Why we're talking today about the cardiac disease in this group of people? So let's look at this graph. This is a study which came from UK. This study was done it's a UK transplant registry study. It was done from 2000 to 2013. It has more than 23,000 people, and they follow these people to see how they lose their graft over a follow-up of 5 years. They find out that out of these 23,000 people, the 6,000 people lost their kidney graft within 5 years after their transplant. And they find out that the number one reason why these people lose their graft was dying with a functioning allograft. Number two reason was alloimmunity, means rejections in the kidney, which was only 25%. If we go down and look at the surgical complications, there were only 8% surgical complication. And when we talk about the recurrence of the disease, there were only 4.2% of the disease recurrence. If we look into these numbers here, if we look at this big pie chart, we will find out that close to the 50% people, they lost their kidney graft while just because of death, cardiovascular mortality. And if we look at the rejections, which thought to be the major reason for people to lose their graft, which is way down. And these are the surgical people, and even then the surgical reasons to lose these grafts was only 8%. So most of these people are dying with a cardiovascular mortality with a working allograft. So let's look at this graph. This is a AHA report which was published in 2003 in Circulation. They compared, if you look at the x-axis here, it defined the different age groups, and the y-axis tells us about the cumulative mortality, annual mortality in these people. They compared the people who are on dialysis to the people with the general population, and they find out that the mortality on dialysis is 10 to 30 times higher than the general population. And if we put the transplant people in between here, they come like in between. We definitely improve their mortality by giving them kidney, but still the mortality is twice as high as compared to the general population. And this is true for all the age group. If we look at the second graph, this is another recent study, which was a European study based on 51 different European registry. They look into all the people who are getting, who have any kind of renal replacement therapy in 2013 and 2014. If you look at the x-axis here, it tells us the life expectancy, and the y-axis tells us the different age groups. We will find that the mortality, the life expectancy in the dialysis patient is half as compared to general population. If we put the transplant in this picture, it stays low, much lesser than the general population. Now, if we compare these two figures together, we will find out that they look very much similar, except that the time difference, the time era is different. The first study is from 2003. The second study is very recent. There's almost 15 years gap between these two studies, but the results are the same. Despite all the improvement in our surgical techniques, better understanding of rejections treatment, we're still losing these people to the cardiovascular disease. To make my discussion much easier afterward, as we all know, the cardiac events can be divided into three major categories. We have ischemic events, we have arrhythmic events, and then we have the heart failures. Let's go dive down into each of these particular cardiac event in our transplant recipients. If we look at this graph, this is a study which was done at University of Minnesota. They look into the Medicare database. They compared the people. They took this study from 1995 to 2001. They compared the people who got a kidney transplant, and then they compared them to the people who are waiting on the list to get a kidney transplant. If you look at the x-axis in this graph, it shows the time after transplant, and the y-axis tells us the cumulative incidence of acute ischemia after the kidney transplant. We will notice one thing, that there is a sharp rise in acute ischemic event after the kidney transplant, and this keeps going up till 1 year after the transplant. The cumulative incidence of acute ischemia at 1 year after transplant is 3.5%. If we keep looking at these curves cross each other close to 13 to 15 months, which tells us that after that, the cardiovascular events, our acute ischemia is lower in the transplant recipient as compared to the people who are waiting on the list, but it continues to rise. Let's look at this study. This is a study done at Loma Linda University. They have 321 consecutive kidney transplant recipients, and they look into the major adverse cardiac events in these people. They find out that the incidence of major adverse cardiac event in these people was 6.5% over a time frame of 3 years. And then interestingly, 57% of these events happen within 30 days after the surgery. 67% happened within 60 days after the surgery, and 84% happened within 90 days after the surgery. If we look at these bar graphs, we will find out the major chunk of those events were acute ischemic events. Now let's look at the arrhythmias, in particular atrial fibrillation, because that's the most common arrhythmia we deal with, and how the kidney transplant people do with this arrhythmia. So this is a study which is taken from St. Louis University. They look into the US RDS data, United States Renal Data System Registry. They took it from 1995 to 2002, and they compare the people who have a kidney transplant to the people who are waiting on the list. And if you look at this graph, the x-axis again shows the time after the transplant, and the y-axis shows the cumulative incidence of new atrial fibrillation after the surgery. Here, if we look at these numbers here, the incidence of atrial fibrillation after transplant goes high right after surgery, and it keeps going high. If you look at it 1 year after the surgery, the cumulative incidence having a new atrial fibrillation is close to 3.5%. If we look at 3 years after the surgery, we will find out the incidence goes up to 7.5%, 7.5% in these kidney transplant recipients. This study also looked into the different risk factors associated with atrial fibrillation. They find out that the age is one of the important risk factors. And this is very important here because as we growing our transplant pool, the age is becoming less and less important. The age limitation to get a kidney transplant is getting less important here. Now we have many people who are getting kidney transplant even over 60 or even over 70 years of age. They find out when they look at the age, the cumulative incidence of new onset atrial fibrillation at 1 year after the surgery was 7.5%, which is very high. And when they look at 3 years after the surgery, the incidence goes up to 15%. So as you grow older, your risk to get a new atrial fibrillation after kidney transplant is very high. And then they also find out that any new incidence of atrial fibrillation after the transplant is associated with high mortality and high incidence of graft loss. Now let's look into the heart failure, incidence of heart failure in this special group of people. So here this study is also taken from the same registry. It also came from St. Louis University. They again they took the people from the US RDS, they compared the people who have a kidney transplant, and then they compared them to the people who are waiting on the list to get a new kidney. Here again, the x-axis shows the time after the transplant, and the y-axis shows cumulative incidence of heart failure after their kidney transplant. They find out the incidence of new heart failure after kidney transplant was 10.8% at 1 year after the surgery. And when you keep following these lines, we will find out the incidence goes up to 18% at 3 years down the line. So even if you're going out of the range after the transplant, still your incidence of getting a new heart failure is quite high. And when they look into the different factors here responsible for causing these heart failure, they find out that the BMI is a very important factor here. And this is also, again, a very important variable here because as we're growing over pool of transplant people, the BMI is getting less important. We are getting more relaxed with our BMI limitations. So they find out as the BMI goes high, your incidence to get a new heart failure also goes high. This study also demonstrated that incidence of any new heart failure after the transplant surgery is associated with increased risk of graft loss as well as overall mortality. So let's look at this study. This study is a Canadian study which was done in two major Canadian centers. They have close to 650 people. They followed them for 5 years. It's a retrospective analysis, and they find out any new incidence of ischemic heart disease or heart failure is associated with very high mortality in kidney transplant recipients. So that will take me to the end of my first part of my discussion here. We can conclude that dying with a functioning kidney is number one cause of graft loss in this group of people. And there was a very high incidence of all cardiac events throughout the spectrum in these people, including arrhythmic events, including ischemic events, including the heart failure events. And then we also know that any new cardiac event after the transplant, it is associated with very high mortality as well as the graft loss. So let's go down to the second part of my discussion, where I will talk about the risk factors associated with cardiac events in this special group of people. Here we can divide the cardiac events, the risk factors, into two major categories. We have transplant-specific risk factors, and then we have traditional risk factor. If we look in the transplant-specific risk factor, we know one thing: they have only one working kidney. So it means this patient population, we're going to start this patient population with the baseline CKD. Then we know they have a higher incidence of proteinuria because of having a single kidney and hyperfiltration. They have more proteinuria as compared to the other people. And then they are on special medications, the immunosuppressant, which other people are not. And then there's the rejections. If we look at the traditional factor, we all point them very easily. We have high blood pressure, we have diabetes, we have hyperlipidemias, we have smoking, baseline low GFR, or proteinuria, which are the traditional risk factors for having a cardiac event. Let's focus on the transplant-specific risk factors. And if we are focused on the transplant-specific risk factors, we have to start our talk from immunosuppression, because this group of people are on immunosuppression. This is a report which is taken from OPTN, which is our organ procurement registry, and we look into different immunosuppressants these people are getting. These names may not look familiar to you, but these are the immunosuppression most of the people are on. They find out the combination of three medications, tacrolimus, mycophenolate, and prednisone is most commonly used. 57% of the transplant recipients are on this combination. Then we have another combination where we have a tacrolimus and mycophenolate, where only 27% of patients are on this regimen, and then we have very small fraction on different kind of regimens. But the most important thing here to understand is that more than 50% of people, of transplant recipients, are on triple immunosuppression, which contains tacrolimus, mycophenolate, and prednisone. And why this is important? It's important to look at this graph here. This is collected from all the literature, transplant literature we have, and we know one thing, that these transplant medication, this immunosuppressant medication specific for transplant people, including tacrolimus, which is the most commonly used medication, cyclosporin, mTOR inhibitors, and prednisone. They are associated with increased glucose. They are associated with increased cholesterol, with obesity, and high blood pressure. And cyclosporin is even associated with low HDL. So we know from this graph, from this table, that all these immunosuppressant medications are associated with a huge metabolic derangements. And maybe this metabolic derangement is the reason to have more cardiac event in this specific group of people. To understand better the immunosuppression and its association with these metabolic derangements, I will mention a couple of studies here. The first study here, which published in 2008, it's based on 5 different transplant centers, and University of Wisconsin was one of the participating center in this study. They looked into the steroids. What they did was that they divided their people into 2 groups. The control group was on standard triple immunosuppression, and the intervention group, they stopped their prednisone at 7th day after the surgery. This is a randomized controlled trial, so they followed these people till 5 years. At the end of the 5 years, they find out that the people who are not on prednisone have better glucose control, their cholesterol was much better, and there were less obesity in those people. However, there was no difference in terms of blood pressure. So they concluded that when feasible, maybe it's reasonable to take these people off prednisone and keep them prednisone-free regimen so that we have less metabolic derangements down the line, which may be a reason to have more cardiac events in this specific group of people. Let's talk about one more study. This is a landmark study in transplant world. It's called Benefit Study, which was published in 2010. It was done in 100 major centers throughout the world, and they compared the efficacy of belatacept, which is a new anti-rejection medication, to our standard calcineurin inhibitor, which include tacrolimus and cyclosporin. They look into their metabolic panel at 1 year after the transplant. They find out that the people who were on belatacept have much less incidence of new onset of diabetes after the transplant. They have better control of their cholesterol at 12 months after the transplant, and they have much better blood pressure control at 1 year after the surgery. So they concluded that when feasible, maybe it's a better idea to change our standard immunosuppression, which include tacrolimus and cyclosporin, to belatacept, to reduce these metabolic derangements and eventually reduce the cardiac events in this group of people. So while we're talking about the transplant-specific risk factors, we have to talk about rejection. There's no literature which talks about how the rejection affects the cardiac events in this group of people. So here we came up with our own idea, and we did a study here at UW. We looked into all the kidney transplant people from 2010 to 2016. We have close to 2,200 patients here. And then we look at and divide them into two arms. The people who have acute rejection within 1 year after the surgery are the people who do not have any rejection. We have close to 321 people who have acute rejection within 1 year after the kidney transplant surgery. We find out, and then we look into the variables associated with subsequent cardiac events after 1 year after surgery. We find out that the rejection was the most important risk factor to have a subsequent cardiac event with a hazard ratio of 2.1, followed by age, followed by delayed graft function. But this highlights that whenever we have somebody who has an early rejection, he's a high risk to have a cardiac event, subsequent cardiac event. When we look specifically into this group of people who had acute rejection, and we look at the different treatment, what they got for this rejection, we find out that the certain treatments were associated with high risk for subsequent cardiac events. One of the regimen was dexamethasone with thymoglobulin, with rituximab and IVIG. People have high incidence of cardiac events afterward with a hazard ratio of 2.4. Then we have another regimen where we have dexamethasone, thymoglobulin, plasmapheresis, and IVIG with a hazard ratio of 5.1. So we can see that the more potent treatment they got for their rejection, there's a higher risk to have a subsequent cardiac event. In other words, we can also say that if they have more severe rejection, they have higher risk to have a subsequent cardiac event. Now let's change our gears here and let's go to traditional risk factor. And traditional risk factor, I picked up obesity. Living in Wisconsin, which is a cheese land, we have to talk about BMI, we have to talk about obesity here. So here we did another study in our own center, and the reason we did this study was that there's a huge gap in literature. We have studies done before 2010. All of those studies tell us that the people who have a high BMI doesn't do good. So we thought that let's see if we are making any difference in the current era. Again, we have the kidney transplant recipients, only the kidney transplant recipient from 2010 to 2015. We have close to 1,500 people, and we divide them into three categories, either if they have a normal weight, or they overweight, or if they have obesity. It's a retrospective analysis with the follow-up of 5 years, and then we look into multiple complications happen based on the BMI. Those included how was their length of stay after the surgery, what were the surgical complications, what were the medical complications, what were the cardiac events in these people, and what were the kidney outcomes. Here, specifically, I will focus more on the cardiac disease based on the BMI. If we look at these two graphs, the most interesting thing you will see that only 27% of the patients had a normal weight at time of their transplant surgery. So it means that if you look at the red bars over there, we will find out that close to 60% of the people were either overweight or they have class 1 obesity. So it means that only one third of our people who are getting a kidney transplant have normal weight. So majority of our people who are getting these kidneys are either overweight or they're obese. When we look into the association of cardiac events with BMI, we find out that any kind of cardiac event is much higher in the obese class, and then specifically, the risk for heart failure is much higher as the BMI goes high. And this study validates the previous findings where other studies have shown that the higher BMI is associated with increased risk for new heart failure. So that will end my second part of my discussion today. And we know from these that there are multiple risk factors. These risk factors can be traditional, they can be transplant-specific risk factors. And working in a transplant world, we have to think about the transplant-specific risk factors. And two most important, we always have to look at their immunosuppression, and we always have to look at the rejection. What kind of treatment are they getting? And we should be aware that any kind of rejection treatment will increase the subsequent risk for cardiac events. So let's move on to the third part of my discussion here, where I will talk about the screening of this complicated people. How should we screen them for cardiac disease? And then we'll talk about some preventive strategies. Before going into screening, I want to show this graph. This is a study which is also again done in the University of Minnesota. It's a retrospective analysis. They have close to 1,100 people, and they apply a Framingham risk score to these people. If you look at the graph here, we have a different group of people in the x-axis, and the y-axis shows 10 years ischemic heart disease free survival. So if we look at the line up in the graph and then the bars down there, the line up tell us that there's much less risk of ischemic heart disease in these people. But actual what happened is that they have much higher risk of ischemic diseases. What it means is that the scores which we can apply to general population to predict their cardiac outcomes, or we can assess if they can get cardiac events, we cannot apply those scores to our transplant specific the patients who have a kidney transplant. This is a general strategy we use in our transplant world to see who is at a high risk for a cardiac event after the transplant. So if the people have less risk factors, we usually don't do any testing for heart, just the regular EKGs, but nothing else. If they have moderate risk to have a cardiac event, cardiac disease, we usually do more testing, which include echocardiograms, stress tests before they get a kidney. And if they are high risk, or if they have diabetes for a long time, we go to more invasive strategies where we have cardiac angiograms. Does that mean if we do cardiac angiograms in all our patients, can we predict the cardiac disease in those? To answer this question, we did another study here. Here we look at all the people who have a normal cardiac angiogram. This study era was from 2000 to 2015. We took all the patients who have a normal or relatively normal or non-obstructive coronary angiograms, and we analyze how they do after transplant. We find out that even they have a relative normal coronary angiogram, they continue to have a high risk for cardiac events after the transplant. And if you look at these numbers here, the 59% of the people who have a relative normal coronary angiogram before their surgery, they had a cardiac event after their transplant. And the highest incidence we have in these people were heart failure, followed by ischemic heart disease, followed by arrhythmias. And whenever, this study again shows the same thing, whenever they have a new cardiac event after the transplant, there is a high risk of death. So now let's look at the different variables associated with cardiac disease after 1 year in this specific group of people with a relatively normal angiogram. We find out that there are certain risk factors are there. Even they have a relatively normal coronary angiogram, still they are high risk for cardiac events. And those risk factors included high BMI at time of transplant. If they're on dialysis for more than 1 year before the transplant, if they have high tacrolimus trough at 1 year after transplant, if they have a high HbA1c or uncontrolled diabetes at 1 year after transplant, they're high risk to get these cardiac events despite that they have a normal coronary angiogram before their transplant. So how should we screen these people? The question stays the same. We just have to be more vigilant. Whenever they're coming for their routine visits to us, we just need to have based over assessment on their history, on their clinical, what complaints they have. However, there is no routine test we can do in these people to predict their cardiac events. We cannot do echocardiogram in these people on a routine basis, on asymptomatic patient on a routine basis to predict their cardiac event. Even the more invasive testing we do, cardiac angiogram, even that is not going to predict what cardiac events they're going to get afterward. So still, there's a big question mark, what is the good investigation in these people? Now let's move on to some preventive strategies. So now we one thing that, whenever there's any de novo cardiac event post-transplant, there's a high risk of losing graft and there's a high mortality. So prevention is always better. So let's talk about prevention strategies. We have few recommendations here, and the first recommendation, most important, is about immunosuppression. Because we know this special group of people are on these certain medications, and we need to be very careful with these medications. So we have three strategies here. Either we can avoid, or we can withdraw, or we can minimize. What that means is that, based on our previous discussion, we know that whenever it's feasible, we should keep them on the steroids-free regimens. Whenever it's feasible, we should switch their calcineurin inhibitor to other immunosuppression, especially belatacept, and we can reduce the metabolic derangements these people have, which in consequence will reduce the cardiac event in these people. And when we cannot do that, because based on their risk for rejections, we cannot withdraw their prednisone, or we cannot make a conversion, maybe we have to minimize those anti-rejection medication. We can minimize their steroids, especially after the rejection. When they receive a high dose of steroids, we need to cut back more quickly. Or based on if they have no rejections, they have no risk for rejections, maybe we need to run their tacrolimus a little on the lower side to minimize the risk for all these metabolic derangements. Let's talk about some specific, some traditional risk factors in these transplant people and how to prevent them. One of the major problem in these people is the hypertension. And unfortunately, we do not have any randomized control trial looking into the blood pressure goals in this specific group of people. And we don't have any randomized control trial looking in what medication, what specific antihypertensive regimen we should use in these people to reduce their cardiovascular risk. So we came up with these recommendations based on our own experience here at UW. And based on our extensive review of literature, we find out that we have to individualize these people. If they have a underlying coronary artery disease, they're high risk for arrhythmias, maybe the beta blocker should be the first line antihypertensive line in these people. If they are having issue with their volume, they have a heart failure, maybe combination of beta blocker, ACE inhibitor, ARB, spironolactone, diuretics, maybe that's a better option in these people. If they have more protein-urea, our focus should be reduction protein-urea with a better blood pressure management, and maybe ACE, ARB, spironolactone, hydrochlorothiazide, maybe that's the better option for these people. And when we have rejection-specific, hypertension related to rejection-specific people, where we talk about angiotensin 1 receptor antibodies, maybe the losartan or ARBs should be the first line of antihypertensive medications. So in the bottom line, we can say we cannot apply all the guidelines we have from general population to this group of people. We have to individualize these people. We have to understand what their underlying cardiac risk can be. Let's talk about hyperlipidemia in these people. Here we have ALERT study, which was a Norwegian study, which was done with good follow-up for 5 years. Here they divide the people into two major arms. In one arm, the people were given statins, and the other arm, the people were given placebo. All of them have a baseline total cholesterol of 150 to 350, and when they follow these people for 5 years, they find out that the people who were on statins have much less incidence of acute sudden death or acute MIs. So they propose that all these people should be on statins. And when they look at their LDL numbers, the people who were on statin, their mean LDL was close to 110, and the people who were on placebo, their mean LDL was 140. So there's not a huge difference, but because of the anti-inflammatory properties of statins, maybe that's a beneficial medication in this group of people. We went one step ahead and came up with some more recommendations to protect our patients from the cardiac events. Based on our own experience here, and based on all this literature, we find out that if the people who are on dialysis with high risk for cardiac events, with high cardiovascular risk, they should be on statin when we transition them to a transplant. It means that by putting those people on dialysis on statin, we can reduce their perioperative risk for cardiac disease. As of now, we know that all the cardiac events, including ischemic, arrhythmic, and heart failure, go sharply high right after the transplant. So at this point, I'm going to do the major outlines of my whole talk here. We know a few things here now. Number one, cardiovascular mortality is the number one cause of kidney allograft loss in these people. If we look specifically into these people, they have traditional as well as they have transplant-specific risk factors. We have to be very careful with the traditional risk factors and try to minimize them as much as possible to improve their cardiovascular mortality. And then we also have to pay special attention to transplant-specific risk factor, including immunosuppression and rejection, to minimize the cardiac events in these people and to improve their cardiovascular mortality. The future direction for my own research, we have to answer a few questions here, and there's still a huge gap in literature. Number one, what tests should we do to find out, to predict, the cardiac event in these people? We know that the echocardiograms, the stress tests, or even the angiograms are not very specific in this group of people. So we need to come up with a strategy where we can find out the people who are at high risk to get cardiac events after transplant. The second major thing we need to do is to find out how to optimize your traditional risk factors, all of them, including how to educate them on smoking, how to get their BMIs down before they get a transplant, how to have a good blood pressure control, how to have a good cholesterol control. Maybe by targeting those traditional, which doesn't look huge, but maybe in this specific group of people, we can make a huge difference in their mortality as well as in their graft function. And then the most important question is how we can reduce the risks which are associated with the transplant-specific medications. What's the good point where we need to stop? And this is the most difficult question to answer, as we do not have any specific tests which can tell us how somebody's immune system is doing, so we don't know how much immunosuppression we can reduce. When it's a good time to switch those immunosuppression. Probably by answering those questions, we can improve the cardiovascular mortality in this special group of people. In the end of my talk, I'm really thankful to Dr. Jamali for helping me with all these studies and being my mentor on all these studies. And then I'm really thankful to Dr. Smith for helping me with this presentation. And it's always a pleasure to meet Dr. Smith because you always learn a lot. And I'm really thankful to my whole transplant family, which is always there to help me with all these studies and to support me through all this process. I'm open for any questions.
Questions from the audience? Is there a question? Am I seeing? Okay. Oh, sorry. I didn't see you.
That was great. Thank you.
Thank you.
I had a question about the dialysis patients being put on statins. What is the optimal time? Like when they get listed, should we start it at that time?
So the question is that when should the dialysis people be on statins? So what we proposed, based on our own experience here, whenever they're coming to be listed, when we know that they're going to get a transplant down the line and they have a high risk for cardiac disease, those are the people who benefit the most. They should be on statins. There are huge trials, And all of those trials talk against use of statins in dialysis people, but maybe people who are going to get a transplant, putting them on statin can reduce their perioperative, cardiovascular mortality.
Did you repeat the question?
Yeah.
Okay, right. Any other questions? If I don't see them, point them out. Dr. Giugiaro.
Fine, thank you very much. Do you think are there any studies that show that the weight reduction at the time of transplant or prior to transplant would help outcomes?
So the question is that, is there any studies looking at, reducing the BMI before the transplant to improve their cardiac mortality? So there are no huge trials here. We have few case series, European-based case series where they have weight reduction surgeries before they did a transplant. They reduced their weights from BMI of 40 to 30, and then those cases, but they are like really small case series. They have like 9 people or 10 persons, and they concluded that all of them did really well after the surgeries, just with the weight reduction surgeries. How effective it is, we don't know, because we know that with all these weight reduction surgeries, there are a lot of nutritional component comes in. And then their absorption for all these medications is also very questionable. And then we can also get in trouble with all these oxalate nephropathy, especially in the people who have these weight reduction surgeries. So we really need to have a huge trial, basically looking into what BMI should we target to get a surgery, and how much the BMI should come down to basically improve their cardiovascular mortality without giving them the complications associated with weight reduction surgeries.
Have there been similar studies on other organ transplant patients?
So the question is that, is there any other studies on any other solid organ transplant? Not that I am aware of. Usually we are way ahead with the kidney literature. So most of the other organs, including liver transplant or heart transplant, their literature usually follows what we recommend. So we are way ahead of them. So I'm not aware of any study, BMI specific study done on those people.
Hey, Dr. Aziz, thank you. That was great. I have a question. If the metabolic improvements with belatacept are significant enough that you feel that should be standard of care over calcineurin inhibitors, and if not, why not? If so.
So that's a good question. The question is, if there is so much, advantages, metabolic advantages from belatacept, why we should not make it standard of care? So everything here comes with a price. Belatacept has a lot of advantages in metabolic point of view, but we know one thing: it's a little weaker immunosuppression, and it's relatively a new immunosuppression as compared to the one we're using. Tacrolimus is here in market for more than 20 years now. So that's one of the reasons. And the second reason is that we have to make sure that EBV status, because belatacept is associated with higher risk for post-transplant lymphoproliferative disorders. So we have to make sure they're EBV positive so that they are not at theoretical risk of getting a lymphoma after starting them in belatacept. So that's one of the reasons most of the people are screened out. And number two, it's never a good idea to put somebody in belatacept when they're a high immunological risk. But there are studies going on. There are other centers like Emory, where they're using belatacept as standard of care with a very low dose of tacrolimus. Maybe that's the way to go. We have to make 4-drug regimen where we have belatacept, then we have really low dose tacrolimus, and then we have the other 2 medications. In that way, maybe we can improve their cardiovascular mortality, and at the same time, we reduce the risk for having a rejection.
Did your study include patients who have had more than one kidney transplant? In other words, retransplant?
In the BMI study, no. So they all have the first kidney transplant. Yeah.
That was a great talk. Thank you very much.
Thank you.
How do you think we should draw the line as to who is too high cardiac risk to proceed with transplant and is better off staying on dialysis? What factors should we consider, or how should we approach that?
So the question is that what factors should we consider? Where should we draw the line and not transplant people when there is such a high risk for cardiac disease? I think this is a key question here. We don't know where to draw the line. We know a few things, that there's a huge benefit from the transplant. The people who are on dialysis, they are very high risk for cardiac disease, considering all the volume shifts they have, all the electrolyte disturbances they have. We know that's the reason all the studies shows that the people on dialysis, they have a very high mortality as compared to general population. Now, where the transplant population comes, we don't really know. Are we going to give them a benefit by kidney and reducing all those risk factors associated with dialysis? We don't know about that. All those studies which shows that the transplant improve mortality as compared to when patients are on dialysis, they all have a specific comment there that this can be a selection bias. Because in the dialysis people, we select only the people who are really like the best out of them. And then we transplant them. Maybe there's a selection bias, and it seemed like we have a better mortality when they get a transplant. So that's one of the questions, I think, which we should answer. Yes?
Prednisone is the most, let's say, harmful anti-rejection drug. What % of patients can you actually wean them from prednisone after transplantation?
So the question is that in what percentage of people we can wean them off of prednisone? We have to look at their a lot of risk factors. For example, the people who have their primary disease is glomerulonephritis. We prefer not to take them off prednisone because there's a high risk of recurrence of disease if we take them off prednisone. However, the people who are older with diabetes, maybe these are the better people to take them off the prednisone. The patients who have a polycystic kidney disease, maybe they're the better people when we can take the prednisone off. Majority of the people are still on triple immunosuppression, but that's something new which is coming, and we're trying to take as many as people off prednisone when it's more feasible. And the same is true about the rejection. When they have a rejection, they have a very high dose of steroids to start with, and now we're cutting it down very, in a very fast pace. Rather than keeping them on a high dose steroids for a longer time, we give higher dose of steroids, and then we cut back very steadily and quickly down to 5 milligram or 10 milligram. But we also have to keep in our mind that when we take them off the prednisone, the same trial also showed us that they're a high risk for rejections. So we have to weigh in, where we have to balance.
Thank you. Any other questions? Please come to the front.
Fantastic.